A very good morning, everybody is nearing good afternoon. So everybody is sleeping. So I will be starting from back. And Madam wants to be very interactive. So we are going to have a class on what? Sam. Who is your friend Sam? What is malnutrition? Malnutrition. What is it? You don't have, you haven't got any more. What is it? In Japan, there is a very famous one. What is that? Like that. You haven't heard of malnutrition? No. So there is, okay, you can see the person only. So we have, so malnutrition and malnutrition. Both are there, isn't it? So, it is we are having the most favorable topic favorable part of pediatrics of your HOD, that is nutrition. So madam is here for, so you are all expert in nutrition, so you are having. So what is the word meaning of nutrition? Nutrition, the word meaning means nutricus. Derived from the word nutricus. That means to suckle at the breast. So that is the importance of breastfeeding as far as nutrition is concerned. Okay. So malnutrition is, what is malnutrition? It is something that is either deficiency or excess or an imbalance of nutritional substance that is given to the child that will produce what? Both malnutrition and malnutrition. That is obesity and undernutrition. Okay. So that is regarding malnutrition. Okay. So the revised term has nowadays we are using only what? SAM. So the first person, you can start presenting.
Good morning, myself Dr.Shanavas.A and Shanavas will be discussing on this case. Master Sudesh, 2 months 20-day-old male baby from Kulashegara, brought by his mother who is informant and is reliable, came with presenting complaints of breastfeeding frequency reduced for 2 weeks, skin changes for 10 days and swelling of face and leg for 1 day.
Okay, hold on this. So, what is the importance of age for you as far as when you present a case of malnutrition? You are having name, okay, for identification say, you know it, scientific. So, what is the importance of age?
So, for the etiology.
What so usually any age group less than 1 year infancy. So previously we used to describe malnutrition as marasmus, kwashiorkor like that. So more commonly we have kwashiorkor, marasmus. Usually infancy, it usually have marasmus is the most common thing. Okay, so what about the just present the history present.
The child breastfed up to 2 months of age, frequency about 10 times per day, 15 minutes per feed. Mother used to offer both the breast and each feeding frequency. Urination present, let down reflex was present, 9 feet present, pass 1 to 2 stools per day. 2 weeks back, the mother developed pain and swelling in both breasts. Breastfeeding frequency reduced to only 4 to 5 times per day, with each feeding lasting for 5 to 10 minutes, sleeps for 1 hour and urine 8 times per day. Continued to breastfeed but frequency and quantity was reduced. Skin changes noticed 10 days back initially on bend of right elbow, later extending to the hand and similar lesion developed on the groin area, also involving bend aspect of the knee. The lesion was dark colored initially, then began to peel off. Underlying skin lighter in color, gradually progressed to forehead and around the lips. It was not associated with itching, redness, pain or bleeding. No history of cracking or ulceration on purulent discharge of the skin lesion. 1 day prior to admission, the mother noticed swelling of face and foot which was present throughout the day.
Okay, what is your comment on so far history?
Sir, edema was present.
So number 1 is child was exclusively breastfed. Okay, so when you consider there is an adequacy of breast. What are the parameters that breastfeeding is adequate? Usually,
Urine output is
number 1, duration of feeding. So usually a child should feed for 10 to 15 minutes, 15 to 20 minutes. Child will feed for 15 to 20 minutes. Then child will sleep for 2 to 3 hours. Number 3, child will usually have 6 to 8 urination, and child will have some 4 to 3 defecation, and child will have progressively increasing weight. So all the 4 or 5 points should be there to tell there is an adequacy breastfeeding. So here the frequency of it is 10 times per day. It's almost equal, almost normal. Okay. So according to IMNC, what is IMNC? What is IMNC? Indian medicine? This is an integrated management of neonatal and childhood health. This is a national program. You should know that. So according to IMNCA, a child should have minimum of 8 feeds. Any child who is having less than 8 feeds, you will consider it as abnormal. And there should be at least 2 to 3 night. So if it is there, we will consider it as normal. So here more than 10 times feed, and also 15 minutes is the duration. So you think that it is a normal feed. But there is a by 2 weeks child developed. What is the problem child developed? The mother developed at that time? What is it? Most probably what is the reason? Could be the mass engorgement and subsequent. Could be having some problem with the breast. What is it due to? What is it due to in a breast tubing? It is due to inadequate emptying of the breast. So when there is an inadequate emptying of breast will get retained, and breast will and engorgement of course subsequently will have what is called breast abscess. So something he has not got by breast abscess. There was no incision brain, nothing was done. Okay, but breast will subsequently reduce the feeding time and the duration, everything goes back. So what is it? We will consider it as could be a lactation failure. Here, child has the mother has gone into lactation failure. Why is that? Due to what? Because it was being due to inadequate emptying. So the mother, she is what is the problem with the child? They are feeding both breasts. For one breast, sometimes then going to another breast. What is the problem when it is doing like that? So may not be there. So we will get what are types of milk you know? 4 milk, high milk, cholesterol. Okay. Then transition milk. We are saying starting from there, cholesterol, transition milk, mature. So mature milk could be 4 milk, high milk. What is drip milk? What is drip milk? So when you feed on one breast, milk dripping from the other is called breast drip milk. Then what is called express milk. These are different types of words we use for this. So some lactation failure, secondary lactation failure might have been happened because of the inadequate emptying and breast problem. Okay. So subsequently, patient develop some form of skin lesion. Could be some going for the skin change of malnutrition. Okay, so gradually progress to forehead and what is it? This spread all over the body. Not associated itching, redness, bleeding. Okay, so an exclusive breastfed baby may not develop these things, and inadequate breastfeeding patient will have decreased milk. Okay.
No history of yellowish discoloration, abdominal distension, vomiting. No history of bites, drug ingestion. No history of
bites. What is that? The child is only 2 months. What when? Insected. You have to say that she is having edema. And you so far you didn't tell there was some edema in the float of pencil. Nothing was told so far. Just okay. Insected with insect-viral recognition. Okay, postpone.
No history of cough, fever, cough, fast breathing, earache or discharge from umbilicus, skin pustules. No history of loose stools or vomiting, abdominal distension or decreased urine output. No history of straining or excessive cry while micturition. No history of decreased activity or drowsiness, feeding difficulty, irritability, excessive cry on handling. No history of seizures or abnormal movement. No history of bleeding manifestation.
Okay, why is there bleeding from dust, bleeding manifestation? So any child with malnutrition, there is a high chance of sepsis. Sepsis can manifest as DIC. So bleeding can occur. Seizures are just like meningitis can be occur. Decreased activity, drowsiness, feeding difficulty. Again, sepsis you can consider it as sepsis. You have to rule up. You want to rule up sepsis. You should ask. But why you should? Why you are asking? When you are presenting the case, you will be asking why you ask that question. Okay. The staining by nutrition is for UTI is one of the vocal cause of malnutrition. You may not be noticing. Some other may not be noticing something. So you should specifically ask. Even if there is no symptom, you should do a urine examination and culture to rule out urinary, especially E. coli. Okay. So next.
Child was initially admitted to ward, shifted to PICU due to young age. Close monitoring and supervised feeding was done. No breast milk from mother. Started on infant milk substitute initially by nasogastric feed. Later changed to pulmonary or broken feeds, vitamin supplements and IV medication. Initial weight loss followed by weight gain. Skin lesions are healing and swelling of leg and faces decrease.
There is no picture of the child. You are going to show picture. Okay. I can leave. Okay. So you have the problem. Okay. So whenever you describe a case, you should have one set of symptoms, progression of symptoms, as you clearly describe what is the progression in the hospital. What's the progression? Then presence, you have described everything in detail till the present status. The child is now stable, progressively weight gain. Okay, that's good for a good presentation. So, but the problem is patient mother doesn't have breast milk. Okay, so there was one problem to one breast only or both breasts? Both breasts. Okay. Then.
Past history, no relevant past history. Birth history, second child of non-consanguineous marriage. Spontaneous conception at 26 years of age. No history of chronic illness. First child only 15 months of age.
Okay. So anything you want to say? Okay. So number one, whenever you are saying socio-economic status of malnutrition, you should ask about mother, age of the mother. What is the mother? Okay, number of birth order of the child. Then how was the child progressing during antenatal period? What is IYCF?
Infant, young child.
Okay, so infant and young child nutrition. IYC feeding or IYCM. Madam is propagator of IYCF. Okay. So we had a conference of national conference of IYCF in Kerala recently. Okay, under the guidance of Madam. So you should be what is the health status of the mother? You should concentrate on how was the mother's nutrition and whether iron was given properly. How many iron tablets should be given? How many iron tablets should be given to the mother? How many? Okay, so previously we used to give 100 tablets. Now 180 tablets. What is the strength of tablet? 60 milligram and 500 milligram of folic acid. So you should know all those things and also about pediatric iron preparations also. You should some of the occasion. So whether it was received or not, you should tell. Okay. So what was the
Antenatal booked ANC at local hospital. Pre-pregnant weight was 38 kg. Her BMI was 19 kg per meter square. But the weight gain during pregnancy was 9 kg.
Why you got what? Let's say what you said, but the weight gain was 9 kg. You said?
Sir, she is normal weight only, but during pregnancy she should have gained 11 to 16 kg.
Okay, so depending on the BMI, you should have, you can go up to 9 to 16, 11 to 16 kg. But 9 is okay, reasonable. 10 kg weight gain of weight during pregnancy is okay. But you should consider it along with the BMI. Okay, very good.
No history of fever with rash, drug.
Can you tell some problem? What is the problem with the fever with rash?
Not symptoms.
Okay, what is the diode congenital rubella syndrome? These are things we usually ask. Let's say ask. Triad congenital rubella. Already you are presented. Congenital rubella syndrome. Right? Previous case, cataract, VDA, sensory neural Sorry. Okay. Then, drug is. Madam, can you tell me antibiotics given to the mother that can adversely affect the fetus? Antibiotics given to the mother that adversely affect the fetus. Antibiotics. Tetracycline, chloramphenicol can produce. Tetracycline can produce the enamel hyperplasia. Then chloramphenicol can produce creatinine, like that. So when you ask, so you will ask. So what is the maximum radiation exposure that is permissible in non-pregnancy? 5 right. So many persons are saying UTI is also very important because of that can produce premature labor and delivery and also UTR bleeding. Okay, next. Now, what about the table you are shown? What is that? Mother cell. Okay. Okay, next.
Second trimester, history of anemia for mother managed with oral iron and IV iron. History of gestational hypertension on medication. No history of gestational diabetes mellitus. Beginning felt at 5th month. First dose of TD taken. UST done at 5th month normal. Third trimester, total weight gain during pregnancy was 9 kg. No history of gestational diabetes mellitus, UTI, bleeding per vagina, and pregnancy-induced hypertension present and was on treatment.
Okay, so patient mother is having diabetes. What problem you expect to the fetus? Microsomia. The baby is born and you are house surgeon. Mother is having diabetes. Baby is born. You are the house surgeon. What will you monitor? Very good. So many persons are saying hypoglycemia. We should monitor closely for hypoglycemia. What is the meaning of hypoglycemia? 40 or you can say 45. After newborn baby, any value less than 60 is hypoglycemia. That also you should know. Okay. Then.
Natal hospital delivery, full term lower segment cesarean section indication, breech presentation, 2 packed cells transfusion, sterilization done, small for gestational age, baby weight 2.25 kg, baby cried soon after.
What is the normal birth weight of a newborn? 2.5 kg. 4.5. That's little high. 4. Who is a term baby? Who is a term baby? As far as gestation is concerned. Go on, sir. Yes, please. 10. That is 7. Till 42 weeks. So 36, 6 by 7 to 41, 6 by 7. After 42 weeks, post term. You should know all these terms. Okay, here it is a small for gestation age baby, SGA baby. Okay, by definition, what is an UGR baby? A UGR definition. Less than 10% of the intrauterine weight. Okay, then.
Postnatal, breastfed within 1 hour of delivery, urine and meconium passed within 24 hours, no history of hypoglycemia, neonatal seizures, neonatal jaundice or NICU admission, was discharged on postnatal day 18.
What is your BFH? What's the latest BFH is name? MBFH. So what is mother? Baby. Okay. Then what is mom? You are everybody is madam.
Absolute opposite.
Okay, proceed. So far, what are the problems that she has mentioned? The child was at birth, there is a closely spaced delivery with some antenatal problems with anemia on treatment. During delivery itself, patient had some problem, mother had problem of transfusion. Even in spite of the patient born, the baby was born 2.25 kg. Isn't it? No bacteria and breastfeeding was started normally till 2 weeks postnatally. Then mother there are some breast problem and lactation failure. Okay, so next.
Development history, social smile was pleasant, no head control, vision follows objects, hearing quietens to sounds, no developmental delay.
So what is a global development delay? What is a global development delay? Global development. Define a global development.
Loss.
Okay, everybody is prompting you. More than?
Sir, more than 2 domains will be delayed.
Okay, so what are the domains you consider? Gross motor and finer, gross motor and fine motor together as a single domain.
Motor is one.
Motor domain 1, then language, then social. Vision and hearing can consider. So tell one condition that we can have an isolated language hearing. Very good. Nice. Isolated motor delay. Isolated motor, only motor vectors are affected. Is a predominant, is a predominant motor involvement. It is not an isolated motor involvement. Isolated motor involvement is little. So you have muscle to act. Neuromuscular disorders. The malnutrition can be isolated gross motor delay. Then these are the severe systemic diseases. Severe systemic disease, heart disease. See, a child with severe heart disease failure can walk, run. So you can have isolated gross motor delay. This can, already you have asked about what is developmental regression. What is a regression? Regression. When they attain milestones are lost, we can consider regression example. So, neuronal soil disease, like so many conditions. Okay, then proceed.
Diet history. Breastfeeding started within 1 hour of delivery. No history of prenatal feeds. Prior to admission, was on breastfeed, was reduced. Feeding about 4 times per day, sucks for 5 minutes, sleeps for 1 hour, urine 8 times, 1 stool, night feeds was present, no let down reflex, and ragi 1 spoon in 1 glass, water twice daily.
When was it started? Ragi.
2 months.
Just you are saying ragi was given?
What time?
You are simply saying it like that? You should tell. You are not supposed to use the word weaning. It was started at 2 months. Or just after 2 weeks. Was it started 2 weeks, 2 months? At 2 months started.
2 months they start.
Okay, then.
Approximately 33 kilocalorie plus 0.5 gram protein in addition to breast milk. Absurd 170 kilocalorie plus 2.5 gram protein. Expected is 423 kilocalorie plus 7.3 gram protein.
Will you get this 425 calorie? 423 calorie expected from where? Which formula used? You said
Polysaccharide or ICMR? What is ICMR?
ICMR how much? Less than 6 months.
530.
Okay, that's why this is ICMR recommendation. Why you 2 months only you are selling like this. Okay. Then, so what is the problem with this diet? Your diet, you are presenting a case of malnutrition. Diet is very important for you. What is it? What is important?
Instead of exclusive feeding,
You should child should have an exclusive breastfeeding. Child was given on ragi, complementary feeding with the ragi. What is rate ragi? It is a very diluted form. 1 spoon in 1 glass 200 ml, and that too you are not supposed to very high only carbohydrate. Ragi contain very few protein, so you should have to give protein. So if you have changed to breast milk changed to cow's milk, no problem. Because contain good quality proteins there. Even though it is not as good as breast milk, it would have been cow's milk. So it's not that they gave ragi that will be very diluted form. So that is inadequate to that point also. So first thing, unusually space of low space in the during pregnancy. Second, patient was born preterm. Not term, but 2.3 kg. Patient was anemia. Mother had anemia. Then fourth is lactation failure with early complementary feeding with very inadequate complementary food. Okay, then. So many problems now.
Not on any supplements. What supplements?
What are supplement you offer a child after born? When you send a child to home, what are the vitamins you
No
give?
birthday baby. What all supplements are you?
vitamins, micronutrients should be
Other than
zinc,
All
folic
babies.
acid, vitamin K, vitamin E.
okay, all babies will give vitamin K. Then say what is a thing that is deficient in breast milk? Vitamin
Vitamin D.
Vitamin D. You will give every baby vitamin D. Then in a preterm baby, what will you give? Iron you can give. Okay. So these are things that you can supplement. Okay, then.
Immunization history at birth, BCG,
Okay.
oral polio vaccine.
You can skip this.
Okay. So immunization is complete. Okay, what is AEFI?
What are the types
So what is AEFI, you know? Okay. So there are 5 groups, you know. May not be asking sometimes. Sir was saying if you want to give more mark, we will ask. So vaccine product writer. So when you give DPT, we can have fever, pain, like that's a vaccine product writer. Then vaccine quality. When you give OPV, sometimes the OPV may get potentiation of this toxin may get activated, can have paralytic polio. Like that's a vaccine quality related. Then programmer. Something instead of giving intradermal, if you give subcutaneous, what will happen? Can have BCG adenitis. Then unrelated and also this unrelated, totally unrelated. See your vaccination, getting so loss of points failed instead of so that is points like that. These are the types of we advise them for AEFI. Okay, what is a serious AEFI? Have you got a serious AEFI? Any AEFI that means hospitalization is AEFI. Serious. That also we use to ask. Then proceed.
Family history, elder sibling is 15-month-old, birth weight is 1.5 kg, now it is 8.5 kg, developmentally normal and immunized for age, no other significant illness.
Okay.
Socioeconomic history belongs to class 4, upper lower class according to modified Kupusomi scale of 2024.
What are the things we can consider? What are the 3 things that you consider for class 3 Kupusomi?
Father's education.
Education.
Father's job.
Education gives how many points? 7 points. Occupation 12. Okay. Total how much? Okay. Not much.
General examination, irritable infant with apathetic face with amplitude in situ, tailor present, palmar tailor present, excluding crease.
What is the best method of looking for para? According to IMNCA. So you should keep, not like this, you should keep the hands
with your own hand over your hand.
Somewhere
Like,
with your palm.
then compare.
So that's it. That's according to IMNCA. Severe para is identified this way. Okay.
No interest, sinuses clubbing, generalized lymphadenopathy, bilateral pitting, pedal edema, extended obtrusion, warm on touch.
Where will you look for edema? Pedal edema? Normally in previous case nephrotic syndrome. Where was that told? Just above the, not over medial malleolus, just above the medial malleolus, press for 10 to 15 seconds and look for depression. So that is what is called ankle edema. You are looking for, you should look for, in a case of nephrotic or renal case, you should look for ankle edema. So here where will you look for dorsum of the foot. That is the difference between malnutrition edema and which is a bilateral dorsal pitting edema. So that's we should be very clear. Okay.
Vitals, temperature 98 degree Fahrenheit.
What is the importance of temperature for you? Yeah, each point we are asking questions. So you should look for hypothermia. Very good. So hypothermia is a complication of malnutrition. So always look for it. Okay.
Pulse rate 147 beats per minute. Regular normal volume character. No radiofemoral delay. All peripheral pulses well bilaterally. Respiratory rate 34 breaths per minute. Regular abdominothoracic. Blood pressure 72 per 40 mm in the right upper arm. Capillary filling time less than 3 seconds.
Okay, so all the vitals are normal except for tachycardia, heartbeat is on the higher side. 147 is I think 2 months. Okay, you can consider as normal factor.
Like a fetus, no? 140.
Head to foot examination. Head size appears normal. No frontal bossing or pain.
What is the importance of head size in the case of malnutrition? Anybody? Malnutrition head size. So it is said that previously we used to say head circumference is normal. It will not be much affected because of the brain sparing effect we used to tell. But nowadays we know that even the number of neurons are there normally, then normal. We can have decreased myelination, decreased arborization, synapse formation, also including neurotransmitter products. All these will be affected. So step size may be on the lower center even in malnutrition. Okay.
Anterior frontal open measures one.
When will anterior frontal close?
Okay, very good.
So many percent. 9 to 15 months is the time of closure, and more than 18 months, 1.5 years, it is not closed, we consider it as delayed closure. We should look for hypothyroidism, vitamin D deficiency, hydrocephalus, so many conditions. You should know some conditions. Then, PF closure is what is better? From birth to before 4 months, it can be closed, and birth itself or before 4 months, it should close. Okay.
Hair dry, pressureless, sparse and straight, no localized alopecia, no flaxing.
What are the hair changes in malnutrition? You can
Flaxing.
that is the most least common of where we say flaxing. In those areas where there is famine is there. So when there is some famine there is time, there will be hypopigmentation. When they have good nutrition, become black. So that's the flaxing. So the most common is hypopigmented, sparse, lusterless, hypopigmented, sparse hair. And you can have what is called easy pickup. You just pick it up, so it will be coming so many hairs around. Then what is called red hair. So the other name of kwashiorkor was red boy. So kwashiorkor, red, somewhat reddish hair can be seen in case of kwashiorkor. So that means what is the cause of just that one? You know whether anybody knows what causes hair changes in malnutrition? What is the content of hair? Melanin and keratin. Where is from where melanin in black person? Thyroxine, phenylalanine, like that. And also it can be pyridoxine deficiency can also be some problem. Okay, like that. Then face.
Face, apathetic appearance, moon faces.
Where why Cushing syndrome or moon face? Previous season Cushing syndrome, moon face, and then nephrotism face. So this again, cortisol is excess in case of kwashiorkor or malnutrition cases can have mooning of face. Okay.
Eyes pale or present, no periorbital edema, no conjunctival or corneal cirrhosis, no corneal scars, no white spot.
Okay, you should look for signs of vitamin A deficiency definitely because it is very common to have. So you know what are the X1, X2, X3 WHO classification of vitamin A deficiency, isn't it? Okay, you know then.
Fundus, no chorioretinitis, oral cavity, angulus, stomach.
You have to look for fundus. But you don't tell fundus because
Babies looked.
even babies are not used to it. Okay.
Oral cavity, angulus, stomatitis present, cheilitis present, failure of tongue present, no glossitis or bleeding or no.
What are the oral cavity changes of malnutrition? Number 1, angular stomatitis, cheilitis. Then, so glossitis can be there. Then, where will you get smooth atrophic tongue? Smooth atrophic tongue. Iron deficiency. Will you get the red leafy tongue? Okay, iron deficiency. Can have both can be medial folic acid can have red leafy tongue. Okay. Then.
Here, no discharge of tragal glands, so swelling between the ear, neck, nose, belly.
Okay, you look for hypothyroidism. Now all the changes. Okay. Then.
Skin, hyperpigmented scaly skin lesion present over groin area, right elbow fracture, extending to arm with desquamation to reveal underlying raw areas which are hypopigmented, mild erythema over perineal region.
So what is that lesion that is you are showing this?
Flaky pain.
Okay, so this is somewhat flaky pain happens. So usually this flaky pain is usually seen in extremity. Both are seen in kwashiorkor. Nowadays we will not use the term kwashiorkor. So we use only SAT. So nutritional dermatosis we call it as nutritional dermatosis. And the flaky pain is usually seen in the extremities. And also here what is the crazy permanent is seen usually here. Okay. So crazy permanent is in the extremities, isn't it? Transport, you know the best transport is usually have feeling of their pain. That is great. That is flaky pain. That is in extremity. Here is a crazy one. In the inguinal region or flexural region is
Shiny skin, no cracks or ulceration, pustules, petechiae or purpura,
So when you examine head foot examination malnutrition, you should comment on the head. Other abnormality you should look for already is anterior condylella may be wide open. Okay, anterior condyle usually wide open, posterior condyle may be palpable. Then you can have what is called features of rickets in the head. What are they? You can have frontal foci, parietal foci. So what is called? What type of head? What? One hot cross bun. When you cook or bake hot cross bun? No, like Eastern lines are. So you can have hot cross bun. There will be a depression here. All the four will be prominent. That's called a hot cross bun appearance of head. Then capital quadratus is the sign of conditions. Then you can have delayed. Then in oral cavity you can have delayed emission. When it comes to the chest, you can have a PGN chest deformity, Addison surface, and also recurrent rosary. Where else will you get rosary? Rachitic rosary. Where else will you get scorbutic rosary? Why will you differentiate between these two? Non-tender. So it is a scorbutic rosary. So you can see where there is cartilage is deficient. So defective osteoid formation. So there will be subluxation of the osteochondral junction. So that we can produce painful rosary in case of scurvy, and also pain smooth in case of rickets. So you can have a PGN chest deformity, rachitic rosary, Addison sulcus. All these can be there, and you can have a protuberant abdomen. Abdomen may be protuberant in case of then you can have limbs. You can have widening of the wrist, and also you can have tibia, going of the tibia, and also there not like the features can be there in case of rickets. Okay, so head foot examination, every point is very important for malnutrition. Okay, coming down the point.
Weight for age, for 11 weeks expected, the observed age is 3.
You can talk with that table.
The weight for age observed is 3.2 kg, expected is 6 kg. The inferences, the standard deviation is below -3, therefore it is severely underweight. Length for age, it is 55 cm, observed is 55 cm, expected is 60 cm. The standard deviation is between -2 to -3, therefore it is moderate starting. Weight for length, observed is 3.2 kg, expected is 4.3 kg. It is between -2 to -3 standard deviation, therefore it is moderate wasting. Head circumference, observed is 38 cm, expected is 41 cm, there is no matter.
So what is your comment? Tell your comment regarding.
There is more extent in wasting.
So look on the last table. -3 is that score. Weight for age, weight for height. Weight for length is -3 to -2. So moderate.
Is it ma'am or Sam?
Sam. What is that? What is that?
Edema.
Edema is the so why are you looking at the mid-arm circumference? So yes, if you are coming for PG, you have to look for weight. The length is less than 66 cm. When the length is less than 66 cm, you should look for the mid-arm. Here you need not remember also. Okay, you know only 6 months to 60 months. Mid-arm circumference less than 11.5 cm is SAM. Edema, bilateral pitting edema is SAM. And also weight for age, weight for height less than -3 standard deviation is also SAM. Here edema is there even though the other abnormality is in the -2 to -3 standard deviation is SAM. Okay.
Examination of abdomen, inspection, shape of abdomen, normal, no distension, unauthorized swelling, all equal with respiration, skin over abdomen normal, umbilical central and inverted, external tenderness, scrotal double doses present, and hernia orifices are normal. On palpation, abdomen is soft, no localizing temperature, tenderness or guarding. Liver palpable 2.5 cm in the mid-clavicular line. Below right costal margin, soft in consistency, round margin, smooth surface, not tender.
What is your comment on liver? This is normal, 2 to 1.5 centimeters. What is the abnormality you expect in the case of malnutrition or some in liver, you can have what is called fatty liver. What type of fatty liver? So there is a fat deposit from periphery to center, fat is being deposited in the liver. So fatty liver is a feature usually have, but here is a soft round. So it is a soft rounded margin liver. It is a normal liver, only 2 centimeter, 2.5 centimeter.
Percussion, upper border of liver is left intercostal space, liver span 5 cm, normal shifting donors of urethral, auscultation, normal bubble sound heard. Other system, respiratory system, normal vesicular blood sound, equally heard, no added sound.
Patient for the respiratory system can have pneumonia. So patient can have pneumonia in case of malnutrition. Why infections are very common in malnutrition? Previously sir told infections are very common in nephrotic syndrome. Just like here. Okay. So you said there are skin is below. Infection organs can easily get into the circulation. Then our immunity, because of the all it is just like HIV, like all the T cell, B cell, neutrophil, all the components of the immunity is defective. So even the number of neutrophils are normal, their hemotaxis, intracellular killing, everything is happening. So it is a very high chance of.
What is the term? Postgraduate. Sir said it is like HIV. Nutritionally acquired immunodeficiency. Next.
Okay, so you can. So what type of infection is more common? Due to gram-negative organs. So you have to consider when you start antibiotics, you should give proper antibiotics that cover the gram-negative organs. That's important. So, okay.
Serious effects with left foot intercostal space in midclavicular line, S1 and S2 normal.
When you have some abnormal serious malnutrition, due to what? Due to anemia. So usually assistance. Anemia can produce a cardiomyopathy. Can there be small heart? So microcardia, around 2-3 reasons we used to say is marasmus is a cause of microcardia. Okay, other two. Okay.
CNS tonal reflex.
Okay, can have hypertonia, hyperreflexia.
Summary: 2 months, 20 days old male
Okay,
baby.
already you are. Okay. Your diagnosis.
Diagnosis: faulty infant and young child feeding practices include exclusive breastfeeding, which is absent. Bottle feed was present, early introduction of weaning was present, micronutrient supplement was absent. The short for gestational age baby with severe underweight, moderate stunting, moderate wasting, bilateral pedal edema, skin and hair changes with multiple micronutrient deficiency in the form of anemia, clinically presented as edematous SAM, kwashiorkor, immunized for age with normal development.
Okay, in single what is your diagnosis? Single word. Edematous. So it is a edematous. Diagnosis edematous. Then what are the predisposing factors you have already described? What are they? Number one, we have already told about the time you have described. Is due to inadequate spacing from being there to anemia, then also problem in the perinatal period and also postnatal. So like that. So you should tell what is your diagnosis? Diagnosis edematous, immunized for age, normal development. Why? Some develop, you should tell the ecology of malnutrition. So madam has already told all this to you. So you should like that. Then, so the problems.
What is the better term for weaning?
You are not supposed to use, we will not talk about weaning. How do you get this word weaning? No textbook, we are also not telling the word weaning nowadays. You should tell only complementary feeding. Okay. Okay, then what are the things? There was no social actually.
The management includes 2 phases, which is stabilization phase and rehabilitation phase. The stabilization phase comes from 2 to 7 days and the rehabilitation phase starts from 2 weeks to 6 days. There are 10 steps which are divided into the stabilization and the rehabilitation phase.
Okay, so just one. When will be this? So okay, so management of malnutrition. So will be there is no problem in diagnosing malnutrition, isn't it? So she has very well described how you will diagnose malnutrition from the history. So we have started from the antenatal history, natal history, there's immediate posting history, everything. Then based on the anthropometric parameters, we will under health food examination, we will diagnose SAM. Or then what we do? Investigation for SAM. So what are the investigation needed? So the investigation that we need is to diagnose the complications of SAM. What are the complications of SAM? First six are the complications of the SAM. One is hypoglycemia. So what is hypoglycemia in SAM? Less than 54. We said another definition. Newborn hypoglycemia is different from that. This here is 54 milligram per deciliter. How will you treat? You are having a slides there also. You want that? Okay, okay. Then should be. That is you lose the chance. You do it.
Treatment of hypoglycemia can be divided into asymptomatic hypoglycemia and symptomatic hypoglycemia. For asymptomatic hypoglycemia, we should give 10% glucose or sucrose solution, IV infusion. For symptomatic hypoglycemia.
So asymptomatic or symptomatic?
No,
Asymptomatic is oral glucose, 10% dextrose, 50 ml of 10% dextrose should be given, followed by you give for F75 every 2 hours. Feed with F75. You know what is F75 again? F75 is a fluid where you use. Okay, you will have 2 teaspoons of sugar. That is 10 grams of sucrose in a 10 ml, 1 ounce of milk. 30 ml milk or 1 teaspoon of what? Our formula. 1 teaspoon of formula. 5 grams of formula or 1 ounce of milk. To which we will add 2 teaspoons of sugar and half teaspoon of oil. It will contain 75 calories per 100 ml and 0.9 or we can roughly remember 1 gram of protein. So it contains a lot of glucose. So it will prevent hypoglycemia. It contains more fluid. So you can use even to prevent dehydration. So F75 we can prevent dehydration. We can prevent hypoglycemia. So you start with 50 ml of 10% dextrose orally, followed by F75 every 2 hours. Okay. Symptomatic.
Symptomatic, the symptoms include lethargy, unconsciousness, seizures. For that, 10% dextrose IV infusion.
Will give. Dose is 5 ml per kg, 10% dextrose, followed by the patient is become alert enough to give oral F75, you can give oral F75. Then.
Dehydration includes watery stools. Treatment includes reduced osmolality with potassium supplements, electrolyte supplements.
Okay, so
what's the name of that?
ORS. Dehydration solution for malnutrition. So these three, hypoglycemia, hypothermia and dehydration occurs together usually. If one is there, you should look for the other two. If the patient is having hypoglycemia, you should look for hypothermia. What is hypothermia? Temperature, actually temperature less than 35 or actual temperature less than 35.5. So you should give slow rewarming with proper covering, including KMC. You should try KMC. So proper rewarming, proper covering, and KMC. All the three you should try.
What is KMC?
Kangaroo mother.
Okay, so dehydration. So when you diagnose dehydration in SAM, can you diagnose dehydration in SAM very easily? It is very difficult to diagnose dehydration because the patient could be maybe skinny, very wasted, skinny appearance. So that so you can visit skin darker. So any child with SAM who is having diarrhea, you will consider it as dehydration. But what it does, you should have dehydration. You manage this as some dehydration. When it becomes shock and other thing, you should treat with IV fluid. Otherwise, no IV fluid in malnutrition. SAM, you should not give too much of IV fluid. So you should give more rehydration therapy. That is by resomatism. Best thing you should give. Then regarding hypothermia, that is electrolyte disturbance. Which is the most common electrolyte disturbance in SAM? Sodium. Is it sodium? Potassium. What will be the serum sodium? serum sodium may be normal, but the total body sodium will be high. So you are, because the sodium may be not in the intravascular space. So you are not supposed to give sodium. You should give potassium. How much potassium? Can give what potassium already is usually given. Can give 2 to 3, maximum 4 milligrams per kg of potassium may be given. Then you can give magnesium, likewise. So magnesium can be given. Okay. So then
Infection we said.
infection. So we already discussed about infection. You should start with you should take blood culture and give broad spectrum antibiotics. Even if there is uncomplicated no evidence of infection, you should give oral amoxicillin. So you should give oral amoxicillin antibiotics in uncomplicated SAM, and in complicated SAM you should give broad spectrum ampicillin plus gentamicin. Then micronutrient deficiency. What are the micronutrients?
Zinc 2 mg per kg per day. Folic acid 5 mg per kg followed by 1 mg. Vitamin K supplements 2.5 mg.
5 mg, not per kg.
Total page.
Then 1 mg, not kg.
Vitamin K supplements 2.5 mg intramuscularly. Vitamin A 50,000 international units. If the symptoms is not subsided, it should be given on the 2nd and 14th.
So vitamin A deficiency. When there is a evidence of deficiency is there, you should give 3 doses of vitamin A. When there is a vitamin A deficiency, as well as an eye sign like that. First is depending on the age of the child. Less than 6 months, 50,000 units per kg. Less than 1 year, 1 lakh per kg. More than 1 year, 2 lakhs per kg. And then you should give it 0 next day, also more than. Then what the time of discharge? 14 days. 3 doses, that is for vitamin A deficiency. When there is vitamin A deficiency, you should give 3 doses of vitamin A. Okay. Then coming to feeding. So you should start with, especially this, you should start with the F75, and once the patient attain or regain his appetite, you can change. Here you can only maximum you can give F100 dilated, because the child is very small child. You are not supposed to give any other RUTF like. So you can give F75. You should give what is the dose of F75 that you should give? 130 ml per kg of F75. If there is edema, you should give less, 100 ml. You should give 100 ml per kg of F75 if there is edema. Otherwise, 130 ml per kg. By 3 to 4 days, patient will regain its appetite. Then what will you do? You can give F100, the same dose as that the previous given. Then once you can change to all the time. After 6 months, you can give what is called RUTF. So with what is RUTF? Ready to use therapeutic food. Once Madam's own food is SAT mix. You are also know what is SAT mix. Do you know? What about it? So it's contain rice, wheat, and black. Rice, wheat, black gram in equal quantity. If you are taking 250, 250. Take it, wash it, dry it, dry and powder, and double the amount of sugar.
Sugar 1 lakh.
Same.
Okay, same amount. Okay. 1 lakh.
Obesity mix with obesity.
Okay, so you can like a same quantity of sugar. That is 1:1:1. 4 times. Then you can visit us ready to use therapeutic food. Amardam powder is given to Kerala government is free of cost. You can take everything.
Sattu mix. Sattu mavu. That's a burundi.
So you can give that type of. So what is the calorie requirement for malnutrition correction? That you should know. So it should be 150 to 200 calorie per kg. 150 to 200 calorie per kg of the calorie requirement. Protein requirement is usually 4, maximum is 6. You can give to 6. You gradually increase. Otherwise, for each time you have nutritional recovery. So we need not know that thing. But you may get, you should be gradually increase the protein, and too much of protein is also a problem. So calorie and protein requirement. Okay. Then what will you give? 6. So once you reach the catch-up growth, then this sensory stimulation you should stimulate, you should give tender TLC. Madam, one word, TLC word. When they are students, Madam used to teach us as TLC, tender loving care. You should give the patient, the child, tender loving care with a lot of stimulation. Child will grow. Then child should be sent to nearest Anganwadi. So Anganwadi, how much? How will they get? They will get the double the requirement of the as a normal child. They will get usually 600 calorie and 15 gram of protein is the 300 grams and 15 grams protein they will get from the Anganwadi for the child. In a mother state they will get double that amount. They will do growth monitoring. They will complete the vaccination. The child, you should ensure that child is being followed up in the Anganwadi. Okay, so that will complete the 10 steps. Anything else is there not? So when you start iron to a child with malnutrition, you are not supposed to add during acute phase. You can give when the child you discharge. You should add iron. Why? So iron needs transfer as the carrier protein. So in case of malnutrition, all proteins are the transfer proteins are very much less. So that there will be free iron in the gut and it will produce infection. So there is a high chance of infection with the E. coli. So you will not start iron before the child is before the child is being or the infections are being treated. Okay. So what is this?
Tick sign.
Tick sign. What is it?
Initially there is reduction of weight. There is weight loss due to reduction of edema followed by weight loss.
So when the child improves, patient's abdomen gets replenished, the edema fluid will reabsorbed. So the weight will come down. Then gradually start weight gaining. So that's called tick sign. Okay. So when you discharge the child with malnutrition?
When the weight gain, when the child weight gains
is more than 5 gram per kg per day. More than 5 gram. Usually good weight gain is 10 gram per kg per day. 10 grams per kg.
At least 5 grams.
So 5 gram per kg at least there should not be any edema. There should not be any other complication. And third thing is mother is confident enough to feed the child. So when the mother is very much confident, you are teaching, you are training the mother very well. So in that case, child will, you can discharge the child. Okay. So you should make sure that immunization is complete. Okay. Anything else, ma'am? Finish. Okay. Very good presentation. All the three.
Thank you, Dr. Shanavas, for taking so much pain to explain and to be very interactive with our students. Nutrition to malnutrition. The children are going to the mall and there is a food court and they are ordering this and that and taking everything home and eating. So what will happen? Obesity. Yes. Which case you are more likely